Then the first step in any case is to recognize cues. So this is getting at what's most important. And the NCLEX can ask you this in one of several ways. Most often, they're going to ask what requires immediate follow-up or which findings are most concerning. In our example here for our first question, we're asked, click to highlight below the findings that require immediate follow-up by the nurse. So we have a lot of abnormal things happening, but we're not being asked to identify just what's abnormal. We're only asked to identify those things that require immediate follow-up by the nurse. And although we have a lot of abnormal things here, there are really only 3 types of findings. We have findings that are normal or expected, and you can have findings that are abnormal but still expected. Like, for example, if you have a client with COPD, maybe they have fingernail clubbing and a barrel chest, and that's normal. Those are chronic changes. We expect that. But maybe what's unexpected is they're tripoding and they're wheezing and they're hypoxic. So discerning between those things that are normal or expected and those things that are abnormal or unexpected. And then of those abnormal or unexpected findings, only some of them take priority. And this is where we apply that prioritization framework and look for maybe those life-threatening issues of airway, breathing, or circulation. So I can't overstate the importance of understanding and recognizing your normals from your abnormals. This is going to help you pick out what you need to worry about here and what you can disregard. So I'm going to walk through each of these options and decide if each one is normal or expected or abnormal and unexpected. I'm going to start by just highlighting all of the abnormals, and then we can look at which among those are the priority. So first, she's slightly anxious. If I was short of breath and in the emergency department and missing work because of this, I would be pretty anxious. I don't think this is an unexpected finding. I don't think it's a primary issue on its own. I would say that it's expected for her to be anxious. And then dyspnea. She doesn't have anything in her history that would tell me that she has a chronic lung disease. She doesn't have COPD. She shouldn't be short of breath at baseline. That is an abnormal, unexpected finding that I want to keep in mind. Then her lung sounds being diminished with fine crackles in bilateral bases. If we have crackles, there's something there in her alveoli that has the potential to impair gas exchange. And we can see in our vital signs that it does impair gas exchange. She has a low oxygen saturation. So I'm going to say, yeah, that is an abnormal finding. Sharp chest pain on inspiration. I want to say, as a good rule of thumb, you should almost always be concerned with chest pain, especially in a client like this who has some cardiovascular risk factors, like she's a smoker, she has hypertension, she has obesity, especially because she has this other symptom of shortness of breath. So yes, that is an abnormal finding. For a former 10-year smoker, yes, it's abnormal. This contributes to her risk. Similarly, with a history of hypertension and obesity, these things are important to inform her risk and help us decide what could be happening here. And then her pitting lower extremity edema. Now, this could mean a lot of things. If you have lower extremity edema, I think the first thing many of us think might be heart failure, especially if you have shortness of breath. In this case, it's only one leg, so we know she has an injury there. Maybe this could be some compartment syndrome. I don't really have enough information yet to feel comfortable ignoring this lower extremity edema because it has the potential to be an issue of circulation. So I'm going to keep this one in mind. Pain and swelling getting worse. That could potentially be a hallmark finding of a compartment syndrome or another issue of limb ischemia, keeping it in mind. And then working long hours at a crowded call center. Now, this is going to inform maybe what she has the potential to be exposed to if she's in a crowded environment, but I wouldn't exactly call it abnormal or unexpected. It's just part of the context of her scenario. Now, when we're asked what requires immediate follow-up, that means that there has to be something I can do about it. And usually that is pretty helpful to help you rule out any history items, any chronic things. She might have been a smoker for 10 years, have hypertension, have obesity, but there's nothing that I can really do about that right now. That's already, the damage is done. So what do I have left? Dyspnea, crackles in her bases, chest pain, then lower extremity edema, and pain and swelling in the lower extremity. Everything that I have here could potentially be an issue of airway and breathing or an issue of circulation. So I'm satisfied saying that these are my findings that require immediate follow-up. Then after you recognize cues, your next step is to analyze those cues. Here, you're deciding what could it mean. And again, there are several different ways you could be asked this. Classically, you're going to see which conditions is this client experiencing or at risk for experiencing based on this information, which disease processes could cause these findings, what could go wrong here, what complications could develop, or maybe how would I know if this or that was happening. So to analyze cues, you want to consider what the problem is, specifically considering how those abnormal findings fit together in the bigger picture. We're going to jump to a different case where we're being asked to analyze the cues to determine what the client's at risk for. So in this case, just to give you the relevant cues you're going to need to answer this question, this client with diabetes comes in with a foot wound. I think we actually have a photograph of it. So a pretty ugly foot wound. They've just gone to the operating room and they had it debrided under anesthesia. At this point, we're being asked, which of the following complications is the client at risk for experiencing? Select all that apply. So considering, are we at risk for falls? Well, this is something we consider every shift, right? We look at all of our client findings and decide how high their fall risk is. So things that might put someone at risk for falls are maybe medications they're on that contribute to dizziness or the anesthesia that this client just got, things that affect their mobility or their gait, like maybe a foot wound would be something. So I'm going to say yes, my cues are telling me this client is at risk for falls. Sepsis or a bloodstream infection. Do I have an infectious source? I do. This looks infected. If I'm really not sure, I can maybe look at, yep, we've got a fever, and I don't have labs, but maybe I would also look for an elevated white blood cell count. But it's pretty concerning for infection, and I'm going to say yes, at risk for sepsis. Osteomyelitis, similarly, an infection of the bone that could easily spread to the bone, yes. Venous thrombosis. Anytime a client is hospitalized, they're at risk for a deep vein thrombosis, right? And so this person just had surgery. Anytime you manipulate the vessels or there's damage to the endothelium, you can have a further risk for DVT. So yes. And then delayed wound healing. That's something that's really, really challenging in clients with diabetes is they have this impaired wound healing, and is part of the reason that they struggle with foot wounds like this that fail to heal. So far, all of these cues are telling me that this client is at risk for all of these things. And if you ever aren't sure how to approach a question like this, I like to kind of think of findings in one of two categories. They're either non-specific findings or specific findings. Non-specific findings, those are findings that we can observe but aren't really specific to a certain disease process. Shortness of breath could be a ton of different things. It could be pneumonia, it could be CHF, it could be a pulmonary embolism, a pneumothorax. But then when we start looking at our more specific findings, and you're most often going to find these in your lab results or your diagnostic results, that starts to clue us into what the cause of the problem could be. So a specific finding might be the fever or white blood cell count that we discussed. So if someone has shortness of breath as a non-specific finding, and then they have a fever and an elevated white blood cell count, that's more specific for infection. So that kind of helps me understand this is maybe an infectious cause of their shortness of breath.